Rhinitis has got a great magnitude, or it's a big problem worldwide. In Europe, only 200 million people struggle with rhinitis, and it affects different ethnic groups, different ages, different people from different countries, and it also significantly affects quality of life. And moreover, rhinitis, especially allergic rhinitis, has got a lot of frequent comorbidities, and it's a risk factor for development, for example, of asthma. Now, this is a study by Mull from 2009. And as you can see, these are the most commonly reported symptoms, which range from sneezing, runny nose, itchy nose, postnasal drip, to blocked nose, itchy palate, and so on. Now, it's really not about nasal symptoms. Rhinitis can potentially change your direction of life, direction of career. This is a study by Samantha Walker and Professor Durham on almost 2,000 students. It's a case control study of students that were sitting at national examinations. And you can see that the ones who had the rhinitis at the time of GCSE examinations, they were 40% more likely to drop grade between their practice and final examinations. And if they were taking sedating antihistamines, they were 70% more likely to drop a grade, which can have a massive impact on your life and on your career in the future. Now, as we are talking about sedating antihistamines, especially in UK, they are very commonly used still. And important is to know that they can cause drowsiness, sedation, somnolence, fatigue. And it's because they cross into central nervous system. They cross blood-brain barrier. And a recent study of a recent review of toxicology tested profiles from almost 7,000 fatally injured aviation pilots in US showed that the difedronamine was the most common drug that was found in autopsies, which means about 7%, which is a great number. And therefore, first generation antihistamines are banned from use, commercial and military pilots. Then recently, or in last decades, we started to study the lower or differences and common ground between the lower and upper airway disease, and we found a lot of similarities. Their functional aspects are very similar. Common inflammatory markers, epidemiological observations are very similar. There are common triggers and common therapeutic observations. And this led to unified airway theory. So now we look at rhinitis and asthma. It's one disease, and they are very closely related to each other. 80% of asthmatics have allergic rhinitis, and 40% of patients with allergic rhinitis have asthma. Now, if you really look into nose of patients with asthma, then you will probably find rhinitic changes in all of them. And if we have a look at these results from longitudinal study, 23 years old, long longitudinal study, you can see that the percentage of patients who had rhinitis and asthma, you're more likely to develop asthma when you have got allergic rhinitis at the baseline. And also, you are way more likely to visit emergency department if you've got asthma and allergic rhinitis when in comparison with asthma alone. Now, allergic rhinitis is like a poor cousin of asthma. Allergic rhinitis will not cause usually hospitalization or admissions to emergency department, and therefore it's very often overlooked. But it's important to understand this relation because, as I will explain later, patients with asthma that have also allergic rhinitis can do better from the asthma point of view if their rhinitis is well treated. And this is a study on a school-age children, and clearly there was a outcome that those who have asthma and allergic rhinitis are more likely to experience attacks of wheezing. They're more likely to experience severe attacks of wheezing limiting speech. They're more likely to visit doctor, and they're also more likely to visit school by 9-fold times. And the use of intranasal corticosteroids resulted in reduction or in risk of exacerbations. Chronic rhinitis is defined as a disease where you have to have a minimum of 2 nasal symptoms out of nasal obstruction, rhinorrhea, sneezing, and or itchy nose. And we classify 3 main subtypes: infectious rhinitis, allergic rhinitis, and the non-allergic rhinitis. It's really mainly about allergic and non-allergic rhinitis, where it's about 50-50. So 50% of patients struggle with one, with allergic, and 50% with non-allergic. We need to perform the skin prick test in all patients to understand whether it's allergic in nature or not. And usually patients with allergic rhinitis, they would present with the symptoms in earlier childhood. They would have more seasonal exacerbations, and then obviously they will have a positive allergy testing. Non-allergic patients would have symptoms later in their life, like perennial symptoms, so also in the winter, and very little seasonal variation. And testing will be usually negative. In terms of endoscopy, patients with allergic rhinitis, you would see typical boggy mucosa, pale rhinitic mucosa, watery discharge. And in patients with non-allergic rhinitis, there is a whole spectrum of findings, but lining in general will look more angry, more erythematose, more less swollen, and more inflamed. These are subtypes of non-allergic rhinitis, and I'm going to talk about those a little bit later. What I want to mention that's quite important, what has changed recently, is that there is something what we call local allergic rhinitis, which is allergic rhinitis that only presents symptoms that presents changes within the nose, the allergic changes. If you would take a biopsy, we would see the same type of findings as in the patients with allergic rhinitis, but they would not be testing positive on skin prick testing. But they will also have a seasonal variation of symptoms, and they will respond to the same type of treatment: antihistamines, immunotherapy, and corticosteroid nasal sprays. Classification. We can have intermittent persistent symptoms. Intermittent means that they will last usually shorter and less often during the week. Persistent means that patients will have symptoms most of the time. And then symptoms can be mild or moderate to severe. Moderate to severe, essentially, it means that it affects your quality of life, affects your sleep, and it affects your sports, leisure, problems. They cause problems at work, problems at school, and symptoms are troublesome. And then you can have a combination, any type of combination: mild persistent, mild intermittent, intermittent moderate, and so on. But what is very important to understand is that there are many phenotypes, but they very often, actually in most of cases, there is some combination. Patient can easily have a allergic rhinitis, for example, to grass, with a presentation of symptoms that are allergic in nature in a spring, summer. And there will be also non-allergic rhinitis, which will cause symptoms all year round, given the patient doesn't have a reaction to dust, which can cause perennial symptoms. And then also there can be combination with the anatomical changes, structural problems. So patient can have a septal deviation and allergic rhinitis. So it's important to have an open mind and to properly explore all these options, and then to identify what is the most troublesome phenotype, and that we need to treat. Non-allergic rhinitis. Non-allergic rhinitis, so we have got the greatest group is at the bottom, and that's idiopathic rhinitis. In most of patients will not understand what is the mechanism. These patients will treat with the corticosteroids, and then we have got groups where we understand slightly what is going on. I will start with the top one, rhinitis in elderly, and This is rhinitis which presents with a watery discharge. Nose is usually not swollen. There is atrophy, if anything. And these patients will respond to ipratropium bromide, and it's very reasonable to try it. Now, if it works, very often ipratropium bromide will have only short-term effect, which means only a couple of hours. And patients very often have to use it several times a day, 6 times a day plus. And they will be looking for more permanent solution. Now, video neurectomy or posterior branch of video nerve ablation can give a patient more of a long-term benefit, but because these patients are usually elderly, we have to think twice. Gustatory rhinitis is a reaction to food. Obviously, the avoidance is #1 treatment. Non-allergic rhinitis. This is linked to neurogenic inflammation. Typical individuals that will struggle, for example, like cleaners or swimmers who swim in chlorine pools. And avoidance really is the most important. But for example, swimmers, if they use saline douches, which means to flush away the saline from the mucosa, it does help. And then also occupational rhinitis very often, or the rhinitis improves up to normal within a couple of weeks after avoidance or avoidance of the trigger. Hormonal induced rhinitis. This is rhinitis in pregnant females. So during the and very often when there is pre-existing rhinitis, the symptoms can be unbearable. We tend to continue with nasal corticosteroids, but obviously there is relative contraindication. So we have to, even though corticosteroids stay locally, the bioavailability is very low. We must have a reason to do that. Otherwise, nasal chromones are safe, and they would be usually #1, along with the saline douches. Then we have got a group of non-allergic drug-induced rhinitis, which is a typical group of typical patient is a patient who is abusing the use of xylometazoline, so Sudafed or Otrivin, which you should use less than 7 days, 10 days, and they tend to continue and then use it long term. In these patients, it's very difficult to switch to corticosteroid nasal sprays because abuse of Otrivin will result in increased swelling. These patients will have the swelling, it takes longer until the swelling goes away. So very often I give a patients prednisolone for 7-10 days just to help them in the beginning. And obviously we need to emphasize to stop, and they need to switch to corticosteroid nasal sprays, which sometimes can be tricky. And then lastly, idiopathic rhinitis is treated with nasal corticosteroids. Group of patients with non-allergic rhinitis is more likely, especially the idiopathic, is more likely to be a candidate for turbinoplasty, and they will respond better to turbinoplasty. Allergic rhinitis is really treated mainly with medical treatments. Allergic rhinitis. So first of all, what is really interesting is that we are observing increased incidence of allergic rhinitis. It is rising. So since 2001, it increased by 33% from 5 people per 1,000 inhabitants to 7 in 2005. And there is also increase in the recorded diagnosis by 43%. I'm not gonna go deep into this topic, which is really interesting. What are the reasons for this? Because it's quite vast topic. There is fantastic talk by Professor Stephen Durham online, which I would recommend. You can find it on YouTube. And I will carry on with the treatment algorithms. So in the first place, we prescribe patients antihistamines with allergic rhinitis, which can be given either oral or nasal. Usually antihistamines are oral. Now, we try to avoid first-generation antihistamines. We would always choose third generation ideally. We've got cetirizine and loratadine, which are available without prescription. Loratadine has got slightly less of an effect than cetirizine, but is non-drowsy. When it comes to cetirizine, 1 in 10 patients will have a bit of a drowsiness. but it's also stronger. So this is something you have to take into account. It's not, cetirizine is not completely non-drowsy, but also it's a bit stronger. And then fexofenadine seems to have the best results, but this one is on prescription. Actually now, no, the policy has changed and you can buy fexofenadine without prescription. Next step are nasal corticosteroids. What is important to remember is that nasal corticosteroids do not work instantly. They start to have effect after 7 days, and in 2 weeks' time, they have got maximum effect. And this is what we need to emphasize to patients, because they very often try it for 3 days, it doesn't work, and they stop. And also because this delayed effect, it is quite reasonable in the patients who have seasonal allergies to start before the start of the allergic season. So if patient has got allergy to grass, you will basically start before the onset. There are smart applications online you can use and have a look at the pollen count, so you can really be able to estimate roughly when to start. Now, nasal corticosteroids with azolastine, which means combination of corticosteroids and antihistamines, that's a preferred treatment for patients with allergic rhinitis. It's been proven by numerous clinical trials that this is more efficient. For example, the Mist nasal spray, but they also can be given separately. So that's what I would recommend to allergic patients. And then this is not enough, especially, for example, in the patients with asthma. You can consider montelukast, which is leukotriene receptor antagonist. And then along with nasal spray, saline has been proven efficient. And then avoid triggers. Extremely important, especially in a dust mite allergy. On the NICE website, you can really find very good algorithm for patients. How to, important is to not to have a carpets. It makes a big difference. Changing the covers for pillows, having anti-allergic pillows, and all of this makes quite a big difference. And then with the rising or with the severity of symptoms, increases the need for immunotherapy. I'm going to talk about that later. And you can always step down if the patient is well tolerated or well controlled. Despite good treatment, despite the fact this is a study on almost 1,000 patients, who out of which 72% were taking allergic rhinitis medication. Unfortunately, out of these patients, there is a huge percentage of patients who still struggle with symptoms. And these are difficult to control patients. And we need a new novel treatment that will help them even more. So we have got the known treatments and we've got new treatments. Now, this is a allergic rhinitis immunological response cascade. I will try to explain where the treatments play a role. So we have got the initial phase and then a late phase of allergic sensitization. So the bit on the left side of the screen, this is what's happening when you're a child, when you first meet the allergen. Usually allergen comes through the skin because the skin is not really well equipped to face the allergens, like upper respiratory tract, lower respiratory tracts. The allergen is processed by antigen-presenting cells, dendritic cells, macrophages, B cells, and then it leads to presentation to undifferentiated T helper lymphocytes. Now, the problem is that the body thinks that this is intruder, parasite, and it will lead to Th2 type of response, which is a wrong response. And this will happen with the help with IL-4, IL-13 interleukins. Following that, there is overexpression of Th2 lymphocytes, which are crucial. And then the lymphocytes will switch and induce allergic specific IgE antibodies, which then in the acute phase, next time when you meet the same allergen, they will link to they will bind to the mast cells, and by bridging between two antibodies, there will be allergic response, and that's what we see in the patients with the acute allergic rhinitis. They will have they will have a sneezing, itchy eyes, itchy nose, and that will be because of histamines, because of cytokines, because of leukotrienes and platelet activating factors that are released into the mucosa. And we will see vasodilatation, swelling, increased vascular permeability, which means the watery discharge, and stimulation of sensory nerves, which means itchy eyes and sneezing. And as you can see, we can change every single part of this cascade. And as the research progresses, we know more and more. So I'm going to go one by one. So firstly is the immunotherapy, which is the first treatment where you can treat actually the root cause of allergic rhinitis, not just symptoms, like with the corticosteroids. So we've got subcutaneous and sublingual immunotherapy. And what it is all about, it's about administering on a regular basis allergen under the skin or under the tongue. This is a small amount that is increasing every month, or sublingual is daily. The treatment lasts for 3 years, and your body, the idea is that your body will get used to the allergen, and you will not have the symptoms as bad, and you will need less medication. So you're treating the root of the problem. And this has been confirmed by numerous clinical trials, and it's been put together by Dami in 2019, who compared 3,000 patients versus another almost 3,000 patients in a placebo group. And the primary outcomes that he studied what the studies studied was effectiveness short-term, which means at a time or after the treatment, straight after treatment, and long-term, which means at least a year after discontinuation. And we were looking at symptoms and medication scores. You can very often see that in allergic studies. Symptom score means that obviously we'll have less of the symptoms, and medication score means that you will need less medication. And importantly, in both groups, so which means subcutaneous and sublingual immunotherapy, there was a significant difference in symptom scores and moderate effect in favor of acute of the immunotherapy. And that was the same separately for the immunotherapy and sublingual therapy. And the same outcome we've observed for medication scores, which means the patients needed less medication. There is a small to medium effect. When it comes to long-term effectiveness, we'll be looking just now for the short term. We've got only 4 trials that looked into this. And because the quality of data was not ideal, the meta-analysis was not possible. But in all studies in general, we found, again, beneficial effect. So hopefully in coming years, we'll have more studies that will show us that immunotherapy reliably is showing effect also in the long term. The next treatment I want to focus on is the anti-IgE therapy, omalizumab. So this is a treatment where you block the receptors for IgE, and there are several studies, randomized clinical trials that showed the efficacy. So this is a trial of immunotherapy plus placebo, immunotherapy plus anti-IgE, which is the omalizumab, and you can see the difference between these two columns. So on the right side, these are symptom scores. The symptoms in general are much lower, and the same is for immunotherapy for grass plus placebo plus the anti-IgE. The problem with omalizumab is that it's quite costly, and it is indicated for asthma, but now it is a bit too much expensive to be used in patients with rhinitis. The second group are the treatments that will affect the usually either binding of IL-4 and IL-13, so the crucial cytokines, which means cytokine inhibitors, corticosteroids. First treatment, this is a local treatment, suplatac tosylate. treatment that suppresses the production of IL-4 and IL-5. Long story short, this is a promising treatment because it showed positive results in the first studies, but we need more studies to confirm the efficacy because we don't have enough clinical trials that would compare the placebo and the patient group. Then we have got this very interesting and very well studied and uprising really group of drugs, which are prostaglandin D2 receptor antagonists. So D2 prostaglandins, they play a role both in the acute phase, they promote the inflammation, but they also play a role in a overexpression of Th2 lymphocytes. So there is a bit of a double effect. And therefore, they are very interesting for potential treatments. And therefore, we have now 2 studies that are looking at this. And both studies showed both reducing the symptom scores, but also medication scores. So that in the future might be the treatment that is upcoming. Then we have got botulin toxin type A treatment that is mainly for non-allergic rhinitis treatment, that also has been studied and showed improvement in allergic rhinitis patients. The botulin toxin, what it does, so it blocks the acetylcholine in a synapses, so it doesn't release as much, and it reduces the reduction of muscle movement and gland secretion. So same as in a forehead muscles that is heavily used, you will have also muscle movement reduction in a glands that stimulate the secretion. And if you reduce these muscle movements, then we are hoping that we should have reduction of symptoms. And the studies that have been done so far showed that this is correct, but unfortunately the effect lasted only for 2 to 3 months. Therefore, it has to be repeated. Another heavily studied treatment, especially in the past, is a capsaicin, which normally exists in the chili peppers. And not putting the chili pepper into your nose. Obviously, this is in the form of the spray, and it has to be done as an inpatient because of side effects. It's especially effective in patients with non-allergic rhinitis. So what it does is that it is known for degeneration, desensitization effect of peptidic sensory C fibers, which means vasomotor innervation, and it tends to fix the imbalance in the vasomotor system. And this is the underlying mechanism of idiopathic rhinitis. And so far, the studies that's been summarized in the Cochrane review, you can see the link at the bottom, or link the dimension of that, showed that all 4 studies showed improvement of symptoms. So when I was in Amsterdam at the fellowship, they used that, but the problem is that you have to stay inpatient for that, so it's slightly less practical. Acupuncture, we do not fully understand how this works. There are several hypotheses that it affects multiple physiological pathways at the level of hypothalamus pituitary adrenal axis, and the others, vasomotor pathways. Long story short, we don't fully understand how this works, but when compared to placebo group, there was a significant effect, significant improvement, but not only improvement of symptoms, but also improvement of serum IgE. And as in the research, we very often see, sometimes we do not fully understand the effect, but if we conduct well-designed study, then we have to respect the results. I will firstly start with this slide. So cryotherapy and kinetic oscillation stimulation are both treatments proposed mainly for non-allergic rhinitis. And what it does, very similarly as video neurectomy, it is changing the activity of the posterior branch of Vidian nerve that comes from sphenopalatine foramen. And this nerve, which then runs in inferior turbinate and also in the lateral nasal wall, we believe is responsible for swelling, mucosal secretion, and also sensitivity, which means itchy eyes, itchy nose and sneezing. So if you stimulate it or destimulate it eventually, there should be improvement of the symptoms. One of the ways how to do that is to use cryotherapy. It looks like a gun with a lollipop at the end. It is cold, not initially, but when you press enter. So you will insert this device into middle meatus, into the area of sphenopalatine foramen opening. Then it literally freezes the posterior branch of the nerve, so it induces the axontomesis. So the nerve is not completely destroyed, but it just changes the function. And there has been described in a well-conducted studies. These are not randomized clinical controls to this, but these studies are prospective, multicenter, and single arm. And we've seen decrease in symptoms, rhinorrhea, nasal congestion, sneezing, and nasal itching. And this is 24-month follow-up now. So we believe that the effect can last for a bit longer. Obviously, we need non-allergic rhinitis. We need randomized clinical trial to confirm these results. And then, before I jump to cryotherapy, I skipped kinetic oscillation, which works in a similar way. Instead of freezing the nerve, we can stimulate the nerve using this balloon, which is placed into exactly the same area in the middle meatus. And vibrations can change the activity of the nerve, and again induce the reduction in symptom scores. And we've got one clinical trial which has reported improvement in symptoms. And there was no improvement in symptoms in the patients who had a sham device, so it was placebo controlled. And then, of course, lastly, but this is not a novel treatment necessarily, we have got also neurectomy, which where you need to cut the nerve, but usually in the sphenoid sinus. Unfortunately, the side effect is 35% dryness of eyes and improvement of other symptoms. But what is now popular is the posterior neurectomy. So this nerve, instead of freezing, surgically can be cut using either cold steel or coblation or cauterization. And there is a big, large-scale study from Korea showing that this is very efficient method, and can be also done in the office. Right, and I think we are getting to the end. So what is quite important that the current standards of treatment are effective, they are well tolerated in mild to moderate patients, but there is unfortunately a group of patients with severe symptoms, and they will continue to experience symptoms despite having the proper treatment. And therefore, we need to look for other treatments, especially corticosteroid and azolastine, which is better than corticosteroid alone. So this is now the number one treatment for allergic rhinitis. And then understanding the allergic rhinitis resulted in a new treatments that can really cure, or they're closer to curative treatments than just the symptomatic treatment. I'm talking about immunotherapy. And lastly, the non-allergic rhinitis is still difficult to treat. Medical treatments, conservative treatments are not as efficient, but we have got neurogenic pathways modulators, and then also new surgical treatments that are used with quite a good success. Thank you for your attention.